Hello everyone, my name is Zainab Baksh. I'm a fourth year medical student currently on the academic rotation this month. I'm going to be giving a brief introduction to lab studies. I will be going over the CBC, CMP, Hemoglobin A1C, Lipid panel, and Thyroid panel. We will be discussing different clinical scenarios and using these scenarios to determine what lab studies would need to be ordered and how we would interpret these lab studies. Hopefully this will prepare you for your upcoming lab studies workshop. So let's begin with the first patient scenario. Mr. Sandoval is a 54-year-old male who presents to the doctor's office with fatigue for the past 4 months. He usually bikes to work every day but has become increasingly short of breath. He denies any orthopnea, paroxysmal nocturnal dyspnea, or ankle swelling. He takes over-the-counter ibuprofen daily for chronic joint pain. He denies any diarrhea, constipation, dark stools, bright blood per rectum, or weight loss. But he reports intermittent central upper abdominal pain that is often worsened with fatty, greasy foods. He denies any fever, chills, nausea, or vomiting. On exam, he is febrile with moderate pallor of the conjunctiva and skin. Physical exam is pertinent for a systolic ejection murmur. His hemoglobin level is 8.2. What would you think is the likely diagnosis for this patient? Iron deficiency anemia due to chronic bleeding from a gastric ulcer. So how do we define anemia? Anemia is the decreased red blood cell mass leading to decreased oxygen carrying capacity. It is defined in men as less than 13 grams per deciliter and less than 12 grams per deciliter in women. What are the common causes of iron deficiency anemia? In men, the most common cause is GI tract occult bleeding. In women, menstruation is the common culprit for iron deficiency anemia. It's also interesting to note that a growth spurt can cause an increased demand for iron and therefore lead to iron deficiency anemia in adolescents. There's also cases where you'd have decreased GI absorption of iron, like in celiac disease, or if a patient had a gastrectomy. The classic characteristics for iron deficiency anemia are microcystosis and hypochromia. Hypochromia means that the red blood cells appear paler than normal. Usually in a normal red blood cell, it'll have an area of pallor in the center of it. Microcystosis basically means that the red blood cell is unusually small when compared to the mean corpuscular volume, or the MCV. This would be known as a microcytic anemia. So this is a table comparing the different MCV values and the types of anemias. For instance, like an iron deficiency anemia, this would be a microcytic anemia like we just talked about. This means that the MCV would be less than 80. Other causes of microcytic anemia include thalassemias and anemia of chronic disease. MCV values that are normal within 80 to 100 can also comprise different types of anemias due to leukemia, aplastic anemia, and also hemolytic anemias can be normocytic as well. Macrocytic anemias are commonly due to vitamin B12 deficiency and folate deficiency. It's defined as an MCV over 100. And again, the MCV is defined as the volume occupied by a single red blood cell. This is a nice table just comparing and contrasting the different types of anemias. So you'd probably likely order a CBC in a patient that has chronic bleeding leading to iron deficiency anemia. This is kind of the main way you would document CBC in your notes in your H&P. So you'd have hemoglobin and hematocrit in the center, hemoglobin on top, hematocrit at the bottom. White blood cell count is usually on the left side, and platelets are on the right side. Here are some normal values for CBC. For a white blood cell count, the normal values vary between 4,000 to 10,000. Red blood cell count 4.2 to 5.9 million. Hemoglobin for males 14 to 18 and females 12 to 16. And for hematocrit, males 40 to 54% and females 37 to 47%. For platelets, the normal value is 150,000 to 400,000. So what does a CBC include? Like we mentioned before, it includes your white blood cell count, hemoglobin, hematocrit, platelets, and your red blood cell indices, which include MCV, MCH, RDW, and reticulocyte count. We went over MCV, which is the volume occupied by a single red blood cell. MCH is the average amount of hemoglobin in an average red blood cell, and RDW measures the degree of variation in the red blood cell size. A reticulocyte is a new red blood cell. It's usually 1 to 1.5 days old. It indirectly indicates the bone marrow activity, and it's expressed as a percentage. Normally, it's around 1%. On the right-hand side, you'll see that there is values for the differential. The differential comprises neutrophils, bands, lymphocytes, eosinophils, basophils, and monocytes. You would want to include a differential with your CBC when you suspect that a patient has an infection or a malignancy. When would you order a CBC? Again, likely due to anemia. This could be from various dietary deficiencies like iron deficiency, folate, or vitamin B12 deficiency. Infection, again looking at the white blood cell count, bleeding, menstrual bleeding, GI bleeding, trauma can all affect the hemoglobin and hematocrit. Response to antibiotics, again looking at the white blood cell count in that case, and response to chemotherapy, really looking at many of the values in the CBC, including the white blood cell count and the platelets. Let's now go to patient scenario number 2. 16-year-old female is taken to the ER by her parents who noticed that she was confused and not acting like herself. She also lost 20 pounds without any intention of losing weight and has been feeling fatigued for the past 4 weeks. She had thought her tiredness was due to her getting up several times at night to urinate. The morning of her ER visit, she had severe crampy abdominal pain with nausea and vomiting. Her mother found her to be confused as she couldn't recall that she had class to go to. On exam, she is responsive to questions and a febrile with a heart rate of 120, respiratory rate of 24, and blood pressure of 125/84. Her respirations are deep and rapid. Her oral mucosa is dry. Heart is tachycardic. Her abdomen exam shows mild diffuse tenderness. Her neuro exam is normal. So again, what would we think would be the likely diagnosis for this patient? This patient likely has diabetic ketoacidosis. DKA is defined by the triad anion gap metabolic acidosis, hyperglycemia, and ketosis. The causes include severe insulin deficiency. This could be due to non-compliance with insulin medication or other medications, like steroids, corticosteroids, getting in the way and leading to insulin deficiency. Also, many diabetic patients initially present in diabetic ketoacidosis. There's also many triggers for DKA, which include infection, pregnancy, or any type of physiologic stressor. Some values you'd want to look out for in DKA would be a pH of less than 7.3, so clearly acidotic, and a high anion gap over 15. Glucose levels would be elevated over 250, and the patient would also have elevated serum ketones found on urinalysis, over 5 milliequivalents per liter. They would clinically present with polyuria, polydipsia, weight loss. They could have visual blurring, decreased mental status, nausea, vomiting, abdominal pain, fatigue, and shortness of breath. And they can also present with fruity breath odor from the ketones. You'll see many electrolyte abnormalities in DKA, which makes the CMP very important to order as a test. Again, you'll notably see hyperglycemia. The potassium also can initially be high due to acidosis, but later fall when you're correcting other electrolytes and giving IV fluids. The total potassium stores are usually depleted due to urinary loss from osmotic diuresis from the hyperglycemia. Sodium, potassium, magnesium, and phosphate are also due to the mechanism of osmotic diuresis. The BUN and creatinine can also be elevated due to dehydration. The most common cause of death is cardiovascular collapse, and this is due to all the electrolyte deficiencies and abnormalities that occur with DKA. So how do we manage DKA? Usually by replacing any fluid loss with isotonic normal saline. Over the first hour, initially 1 to 2 liters is infused, and then correcting the hyperglycemia, initially with a bolus, then continuous low-dose IV insulin. We also want to replace any electrolyte losses. For instance, potassium lost. You'd add this to the IV fluids, and phosphate replacement. You want to make sure there's clearance of the ketones, and also find the main underlying cause for the diabetic ketoacidosis. What labs would be important to order? Definitely the CMP to look for any electrolyte abnormalities and the hyperglycemia, and also to calculate the anion gap, and to look at the values of the BUN and creatinine. Your hemoglobin A1C would also be one you could consider to order as well. So this would be how you would document your CMP. Again, there's that fishbone structure. Sodium's on top, potassium on bottom, chloride, bicarb, BUN, creatinine, glucose, and calcium. The CMP also includes your liver studies, which are your AST, ALT, and alkaline phosphate. It also includes the liver studies of total bilirubin and protein studies such as total protein and albumin. So overall, the CMP includes 14 tests. So what's the difference between a BMP versus a CMP? The BMP only has 8 tests. It includes sodium, potassium, chloride, bicarb, BUN, creatinine, glucose, and calcium, but it does not include ALP, ALT, AST, bilirubin, albumin, or total protein. These are the normal values for the CMP. These are the patient's values. So you can see that the patient is hyponatremic. Potassium is slightly elevated. The patient is hypochloremic. Bicarb is very much reduced at 9, well below the normal value. BUN and creatinine are both elevated. Glucose is significantly elevated, and there is a presence of ketones. So why do we order a CMP? We order a CMP to look at organ function, for instance, in the kidney or the liver. We want to monitor chronic conditions such as diabetes, liver disease, and kidney disease, as well as hypertension. You can also monitor specific medications that can cause adverse effects to the liver or the kidney. When would we order a CMP? We would order one just for like a routine blood workup, also as part of an annual physical exam, but also to monitor drugs that can affect the electrolytes, and again to monitor organ function and nutrition status. The hemoglobin A1C is a lab test that measures the average level of blood glucose over the previous 3 months. You order it to screen for diabetes. Normal is below 5.7%. Pre-diabetes would be between 5.7 to 6.4%, and diabetes would be diagnosed as a hemoglobin A1C over 6.5% or higher. How do we estimate hemoglobin A1C? There is a formula you can use to estimate the average glucose, but there's a far easier method to estimate the glucose by the hemoglobin A1C. You can take a hemoglobin A1C of 6, multiply it by 2, giving you 120. And then for every increase by 1 of the hemoglobin A1C, add 30 to the 120. Going on to patient scenario 3. 65-year-old diabetic male smoker with recent MI presents to clinic for a general checkup and cholesterol screening. So you would probably order a lipid panel for this patient. A lipid panel is a blood test to measure lipid fats and fatty substances used as a source of energy for the body. It's comprised of total cholesterol, triglycerides, your HDL, LDL, and sometimes other measurements like the VLDL, ratio of total cholesterol to the HDL, and ratio of LDL to HDL. The patient should usually do their blood work for the lipid panel when they're fasting. You order it in routine health examinations for prevention of coronary artery disease, and also for follow-up to monitor patients with diabetes, hyperlipidemia, and also to monitor different medications that have side effects that affect or cause dyslipidemia. These are the patient's values. His total cholesterol is 300, triglyceride 200, HDL 36, and LDL 224. And you can clearly see, as you compare it to the normal values, that the total cholesterol is markedly elevated, as well as the triglycerides. The patient's HDL is low, and the LDL is also significantly elevated from normal. Hypercholesterolemia is associated with atherosclerotic disease. Atherosclerotic coronary artery disease is a leading cause of death in both men and women, and that's why it's recommended that routine screening of average risk individuals be done every 5 years. The risk factors for coronary heart disease include smoking, hypertension, low HDL below 40, family history, the age of the patient over 45 in men and over 55 in women, and diabetes. Lowering the serum cholesterol levels will decrease the risk of major coronary artery events and death in patients with elevated cholesterol and no prior coronary heart disease. Usually, hypercholesterolemia is managed through lifestyle modification, including starting a diet that's low in saturated fat, that's low in cholesterol, encouraging exercise, and perhaps starting them on a statin therapy. In the fourth patient scenario, a 40-year-old woman presents to clinic with menstrual irregularity. Before her symptoms began, she had normal menses and discontinued breastfeeding 4 years ago. Over 1 year, she has gained 15 pounds and feels fatigued even though she has gotten adequate amount of sleep. Her hair has been thinning and her skin is more coarse on palpation. She has no headaches or visual changes. Pelvic and breast exam are normal. She is not obese and does not have excessive hair growth. White nipple discharge is seen on exam of her breasts. Her pregnancy test is negative. What would you say would be the most likely diagnosis for this patient? This patient has hypothyroidism. This is defined as an inadequate production of thyroid hormone. 95% of cases are caused by primary thyroid gland failure, and the most common cause of hypothyroidism in the U.S. is Hashimoto thyroiditis or autoimmune thyroiditis. The next most common cause is surgical or radioactive iodine treatment for hyperthyroidism. Prolonged hypothyroidism can be complicated by myxedema. Myxedema is a condition in which the patient presents with dull faces, swollen eyes, and edematous extremities from the accumulation of polysaccharides in the dermis. They'll also present with sparse hair and thickened tongue. They could develop an enlarged heart and an ileus as well, with delayed relaxation of their DTRs. Without treatment, myxedema can be a medical emergency. So what would you order in this patient? You definitely want to order a beta HCG to rule out a pregnancy, as these symptoms can present in a pregnant patient as well. You would want to order a thyroid panel and a lipid panel. Patients with hypothyroidism can have abnormalities in their cholesterol metabolism. A thyroid panel will help evaluate the thyroid gland function and help us diagnose whether a patient has hypothyroidism or hypothyroidism. TSH is produced by the pituitary gland, and this helps regulate the amount of thyroid hormone that is produced by the thyroid gland and released into the blood. When the thyroid hormone is decreased in blood, the pituitary is activated and releases TSH, which causes an increased production of T4 and T3 by the thyroid gland. The components of the thyroid panel include TSH, T4 or free T4, T3 or free T3. This is a nice table looking at the differences in the clinical signs for hypothyroidism and hyperthyroidism. You can take a look at it on your own time. Thank you so much for your time, and I hope this helps in preparation for your Introduction to Lab Studies workshop.